better. I'm actually 5 minutes away from tea break, as per your schedule. So whenever the tea comes, we should have it hot.
Look, it will be in the executive canteen, so they will keep it hot.
So you can tell me when you want to begin.
So you're combining both talks together?
No, I'm not.
So first this.
Yeah, I'll take this first.
Yes.
So at the outset, thank you Indian Journal of Ophthalmology and the Aditya Jyot Institute for having given me an opportunity to be here today. Instead of talking on the sample size first, which is much later on in statistics, I'll start with the basics and then I'll go on to sample size calculation, which I will take as the second part of my lecture. I'd like to begin with a quotation from the American Journal of Surgery. It says that a fellow with one leg frozen in ice and the other leg in boiling water is on an average comfortable. Right? So, since all of you all are surgeons here, except me and Vasumati, I think there's a mixed audience, all right. So, this is how most clinicians, unfortunately, view statistics. And what I shall do over the next maybe an hour or hour and a half is to try and tell you that it's really not as difficult as it looks. What I will talk to you about is why statistics, the concept of variation and probability in medicine, and how each one of us in day-to-day life actually deals with statistics without realizing that we're dealing with statistics. I'll then go on to the main topic, which is sample versus population. We look a little bit about data, numerical versus categorical data, parametric versus non-parametric data, and the difference between this lecture and the previous lectures will be that I get to ask the questions and you get to give the answers. Yes? Let's start with why statistics. And that's because variation characterizes much of medicine, variation characterizes much of what we do. And I'll give you 3 examples here. Smoking and lung cancer. Not everyone who develops cancer has ever smoked, and not every smoker develops lung cancer. So, variation in medicine. Differential responses. About a decade back, when I was a lecturer, there was a girl, a doctor in the JJ hospital, who went to take routine prophylaxis for rheumatic fever, benzodiazepine penicillin, in the EMS. She'd been taking it for a while. She collapsed after the nth injection, died of anaphylaxis. Differential responses. And if you look at bronchial asthma as a disease, what you see in adults is wheeze, but what you see in children is cough variant asthma. So all of us as clinicians deal with variation in medicine. How is variation linked with statistics? Diagnosis and treatment essentially, remember, are probabilistically related or probabilistically weighted. For example, if you have a patient who is a smoker who comes to you, you would think, what is the risk of CA lung or CA esophagus because of his smoking? If he comes to you with weight loss, you will think of what is the probability that he has carcinoma lung. And if you actually diagnose carcinoma lung, you will talk about probability of cure or the chance of cure. So essentially, all of us deal with probability, all of us deal with statistics in day-to-day working without realizing that you are dealing with statistics. And yet, it is difficult for us to understand statistics. Why is that? Terminology often does not make sense. Okay? For example, if you look at the word significant, what does it mean in regular English? This is not a trick question.
Important.
Something which is important. Right? Whereas when you talk about significance in statistics, it is A better than B. One is significantly different from the other. If you look at the word error, a mistake, right? However, in statistics, as I shall tell you a little later, and as Dr. Nayak will tell you in hypothesis testing, you have a type 1 error, you have a type 2 error. So the connotations, the meanings of these words are quite different from the way we use them in regular English. The second problem with statistics is that it involves understanding, mastering abstract concepts. For instance, if I were to ask you what is the equation of a line? Anybody? A line. A straight line. Anybody? The equation of a line is y is equal to mx plus c. Bad enough. Y is equal to ax plus b, depending on how we've been taught. Okay? We don't know that. We don't want to know that. How many of you all want to know how to derive the equation of a line? Nobody. Why bother? How many of you left 12th standard so that you could math, so that you could get into medicine? But the wheel always turns a full circle. Yes? So we come back where we had started. So much of what I tell you in the next hour is going to require faith. Simply because statistics lies at the interface between mathematics and science. And I by-hearted this just to tell you why is it to demonstrate.
In the English with faith and then the lie word is
Right. So remember that while it is difficult and frustrating for you to be here, it's also difficult and frustrating for instructors to be teaching statistics. Hundreds of thousands of undergraduates and postgraduates across a variety of majors are required to take stats, maths. Unfortunately, many of us are not mathematically inclined. This is a very interesting quotation that I picked up, that 50% of what you learn about therapy in the next 5 years is wrong. Unfortunately, what you don't know is which 50%. As Vasumati said, everything is evolving. Right. What we will do now is to start with the meat of the lecture, and I'll talk about now the concept of sample and population. Let's say I want to do a research study which is looking at all students who are attending research methodology or medical writing workshops in India as to whether or not they have consumed alcohol in the last 1 month. Can anybody tell me how easy or difficult it is for this study to be done? Let's assume everybody is truthful. I want to do a research study which looks at whether or not people have consumed alcohol, students who are attending research methodology workshops all over India.
So
How easy?
I thought you were asking something.
I am not yet asking. Yes. How easy or difficult is it?
Not really difficult.
Depends, you need a lot more qualifying data.
No, it's a
When
very
you say
simple
what do you
question.
mean by consumed alcohol?
Yes or no question. Very simple question. Yes.
no.
They are truthful, yes.
No, we've said we're all very honest. Mostly.
But it's difficult to get responses.
Very good. Why is that? There are 4 reasons why it's very difficult. 4 or 5 reasons.
One is
One
all
One is
students.
participation.
You have to find out how many have attended.
Let's
Participation.
Vasumati is doing our database. We'll ignore all that. My point is slightly different. Yes, it is difficult. Answer is it's difficult. Why?
Disinterest to get into such type of study.
This question is very simple. We are moving at a tangent.
Difficult or easy depends upon what sort of study
This is
we
a
are
very
going to
simple
plan.
study, sir.
If we are going to include at one center only, at one workshop at
No,
one
I said
center,
all over
attending
India,
30
no?
or 40
Coming to that point, I said all over India. The question is very clear.
Then if it is multicentric, then what sort of study we are being planned, it depends upon that. If it is multicentric spread all over India or outside India, then it is very difficult.
It's very clear. It's all over India. It's
Then
multi-centric.
Then it difficult.
Any
Yeah.
thoughts as to why it could be difficult? It's not a trick question.
You
Huh?
get responses from people. I mean,
We are getting
yes.
good responses. We've discussed that already.
The cooperation between the centers is the major
Let me answer the question. There are at least 4 or 5 reasons why it is difficult to get responses. One of the first reasons is I should have a lot of money to do this study. Fundamental to research is money, right? So I need to buy flight tickets and travel all over India to do this study. I need to find out everything. That's one, cost. Second is all of us are very busy, or at least like to think we are very busy. So time is a big impediment. You have to travel, you have to find people, they have to give you responses. When you do multi-centric studies like these all over India, you need people, no? You can't do research alone. You have to do it as a team. So the third problem is personnel. Right? You need to have people with you, build a team together, make sure that the protocol is in place and stuff like that. So what do? I know that on a Saturday morning, I'm coming to the Wellington Institute and I have a captive audience of, let's say, 40 people here. And I assess the responses of these 40 people and ask them a question. Have you consumed alcohol in the last 1 month or no? And I don't want answers. What have I done really? I have moved from the entire population out of interest to a much smaller sample. What will I do with this sample? What will I do with the information that I get? I will extrapolate the information. I will generalize the information and say that research methodology students are very good or very bad depending on how you perceive alcohol consumption. So if you look at the examples of population, I would say employment status of all, and this is important here, employable people in the city of Mumbai, or blood pressure status of all urban Indian males. Again, these two studies are difficult to carry out. So what do? I stand outside Churchgate railway station and I interview 2,000 people who exit Churchgate railway station and say, are you employed or are you not employed? Or I look at the blood pressure status of 6,000 Indian males from 6 metropolitan cities to answer the question on blood pressure. So in both these cases, I have moved away from the population to a sample, which makes it easier for me to carry out research. Which is the only study in the world which is done on populations? The census. There is no other study which is done on populations. So if you were to define it statistically, the population is essentially the entire set of data about which you are looking for information, and a sample is a subset of the population from which data is actually collected during the course of the study, right? Now if you look at this particular diagram here, this is my population here, and within this I have 2 circles. This is a sample, this is also a sample. What are the 2 messages that you get from this particular slide? Yeah. The sample sizes are different. The first message here is the bigger the sample size, the closer you will be to the population, right? Ultimately, statistics is about extrapolation. It is about generalization. So the bigger your sample size, the closer you will be to the truth. It does not mean that this is wrong. It just means that this particular circle is a little further away from the truth relative to the bigger circle. That's the first message. The second message is that if you have to generalize, the sample has to come from within that population to which you intend to extrapolate your data. For instance, if you're doing a study on mild hypertension, you will not be able to extrapolate the data to patients with moderate hypertension or severe hypertension, which is often the criticism of a lot of studies which we do at KEM. Because we work in tertiary referral centers, we do a lot of work on drug-resistant malaria. The data is often cannot be extrapolated to the community where the malaria resistance may be quite different. So the 2 messages here is your sample has to come from the population to which you intend to extrapolate your data, A and B. The larger your sample size, it doesn't mean that you should have a large sample size. We'll come to that. The better is your extrapolability or generalizability, right? So to summarize the first part of my presentation, in statistics, it is difficult to obtain information from the entire population. Therefore, we rely on samples to make estimates or inferences, and the eventual purpose of statistics is to make strong, robust conclusions from limited amount of information, and statistics really helps us to generalize our results. It helps us to extrapolate our results. Okay? Any questions? You might say that all that is fine, but do I really need to know about biostatistics? I don't want to do medical research. I don't want to publish papers. I don't want fame, glory or money. I just want to do my job well. All of us want to do our jobs well, right? So why should I know about biostatistics? Why am I here on a Saturday morning? Right? If you look at how statistics are misused in literature, 75% of 59 articles in Transfusion contained an inappropriate statistical test or had an error in calculation or interpretation. 19% of 145 articles published in the American Journal of Obstetrics and Gynecology contained serious statistical errors. What are the implications of this? Tomorrow if you read your journal, your own journal, IJO, and there are statistical flaws or errors, the evidence that you use to treat your patients is automatically flawed. Right? So your patient care is affected if the evidence on which you base your treatment and knowledge is flawed. Therefore, all of us need to have some basic, some limited understanding of statistics. It doesn't need to be very large, but it needs to have, you need to have enough information, enough knowledge to be able to appreciate literature, to be able to understand literature, and to be able to apply and use evidence-based literature. Right? So with that, we shall begin. We're all here. At maybe lunchtime we reach here. And as you finish lunch and you come back into the next session, and as I leave to go home, all of you will come down this curve. Which brings me to what Vasumati said earlier. It's all about constantly reading. Everything is evolving. It's also about constantly learning and constantly updating oneself. One single session, one single lecture talk is really not going to do much. Alright, so I'll go on to the second part. Should I break now?
Yeah.
Break? Because I'll start with the data types.
10-minute break. You can go to the cafeteria. There's an executive cafeteria right here. We can have tea and biscuits.
Be at the end of the session and not in the middle. And we'll be back here in about 10 minutes.
So I'll begin with the second part of the presentation, which is essentially on data types. You don't need to write anything down. There is a very small book. It's about 120 rupees. It's called the Statistics at Square One. It's an orange colored book, very small. You get it at most bookstores. Much of this presentation, 80-90% of it is from that book. So I would really recommend that you keep it with you. Almost all of it actually is from that book. Statistics at Square One. It's a BMJ publication, British Medical Journal, and it's written by a guy called Swinscoe, S-W-I-N-S-C-O-W. Data is broadly divided into two types. Right? It's called as categorical data and quantitative data. And what I like in the first chapter of the book is the way he describes how we remember data. Whenever we ask the question, how much, how much is the height of a person, or how much is the weight of a person, or how much is the blood pressure, or how much is the intraocular pressure. That kind of data is called as numerical data. It's called as quantitative data. Because you also measure it, it's also called as measurement data. The reason we call it numerical is because it comes back to you as a number. So numerical data. As against this, you have data which is not numerical, but it's got a quality. For example, what is somebody's color of somebody's hair, or what is somebody's sex. Any data which has got a quality rather than a quantity, and which can be placed into a category, a slot, okay, that kind of data is called as categorical data. And what the book says is, you ask the question, what type? So how much is quantitative, what type is qualitative data or categorical data, right? So categorical data are merely labels or categories. For example, hair color, black, white, brown, red, blonde, etc. Opinion of a patient about his headache, mild, moderate, severe, very severe. Smoking status, smoker and non-smoker. Categorical data is broadly divided into two types: nominal data and ordinal data, each of which is further divided into binary data and non-binary data. What is binary data? Data which has got only two categories. And any data which has got more than two categories is called as non-binary data. So categorical data, what type of data? Divided into nominal and ordinal. We look at each one of them one by one. What is ordinal data? Ordinal starts with an O. There is an order in the data. There is a method in the data. There is a gradation in the data. For example, first MBBS, second MBBS, third MBBS, intern. There is a order, right? Degree of illness, mild, moderate, severe, very severe. Again, an order in the data, a gradation in the data. Blood pressure status, hypotensive, normotensive, high normal, mild, moderate, severe. Again, an order in the data, a gradation in the data. Therefore called as ordinal categorical data. Binary data, data which has got only two categories: smoker, non-smoker, present, absent, immunosuppressed, immunocompetent, positive, negative, male, female. Anything which has got just two categories becomes binary categorical data, which could be either ordinal or it could be nominal. As against ordinal data which has got an order, nominal data is unordered data. Anything which is categorical but does not have an order is called as nominal categorical data. For example, hair color, black, white, brown, whatever. No order, just categories. Opinion of students about this workshop. You could be happy, neutral, bored or frustrated. Again, no relationship between the categories. Smoking status, smoker versus non-smoker. The next kind of data which we discussed in the beginning is how much. How much is the weight? How much is the height? How much is the blood pressure? Data that comes back to you as a number, data which can be measured, data which can be quantitative, and therefore numerical data, quantitative data or measurement data. For example, cholesterol, height, weight, age, time taken by me to complete the statistics lecture can also be measured, right? So that's also an example of measurement data or quantitative data. intraocular pressure, phenytoin, serum, lithium levels. Just like categorical data is divided into nominal and ordinal, numerical data is divided into continuous data and discrete data. So we'll take examples of each one of them. Continuous data by definition is data where you may not have gaps between the data points. For example, if you take serum cholesterol, cholesterol could be 200, 201, 202, 3, 4, 5, 6, 7, or 200.1, 0.2, 0.3, 0.4. Or if you have a really sensitive measuring device, 0.01, 02, 03. So when you have no gaps between individual data points, that kind of data is called as continuous numerical data. Another example is height, weight, blood pressure. All of these, if you have a fine enough measuring device, can be viewed as continuous data. As against this, discrete data is data which has got gaps between the data points. For example, if you look at number of children in a family, you can have 1 child, 2 children, 3 children, 4. But what you cannot have is 1.5 children and 3 3/4 children, right? So you have gaps between the data points, in which case that kind of data becomes discrete data, discrete numerical data. For example, number of students late for this class, number of cardiovascular deaths in a ward, number of pregnancies, and age. Can anybody tell me why have I put age as a continuous variable and a discrete variable? If you see, remember the previous slide, I put age as a continuous variable. I've also put it as a discrete variable. Anybody?
If you want numbers as in age in years.
Yes.
As opposed to when you go to continuous, you can just put age and you can fill in your units.
It ultimately, he's right, it ultimately depends on the question that you want to answer. If you're an adult medicine physician, right, you just want to know whether the patient, or you're doing a study which looks at adult patients, you want to know if the patient is more than 18 years, right? 18, 19, 20, 21, whatever. It doesn't matter if he is 18 years and 1 hour old, or 18 years and 6 days old, or 18 days and 364 days old. It doesn't matter to you, right? In that case, age would become a discrete variable because you're just looking at individual years. If you're a neonatologist or a pediatrician, you might want to know how long was the survival in a neonate. 29 days and 2 hours, or 29 days and 3 minutes, right? So the point I'm trying to make here is that whatever I tell you about data types, ultimately there's nothing sacrosanct about it. It has to fit into the objective of your study. It has to fit into the research question that you're ultimately trying to answer. Right? And to finish this part of the presentation, we'll come to distributions in a little while. Any data which follows this Gaussian curve, which we remember from PSN, is parametric data. By default, this is a continuous line. So continuous data generally follows a normal distribution. We come to distributions in a little bit. Right? If it follows a normal distribution, it becomes parametric data. Therefore, you use something called as parametric tests. And if your data does not follow the normal curve, it is skewed. It's also called as distribution free data, or it's also called as distribution unknown data, in which case you apply a different set of tests. So the only take home message at the end of this hour and a half really is that your type of data and type of distribution will determine the type of statistical test you will use to analyze your data. That really is the take-home message. The rest of it falls into place. What is your data type? What is your test for you? Okay. So now I shall stop talking and you can give me some answers so that we break the tedium of the presentation. Which of the following, you can give group answers. Which of the following are categorical data? I did engineering for a while before I entered medicine. Horrible. I was one of the 3 girls, so I used to get picked out. So I said, please give group answers. Number of episodes of disease in a patient over a year. What is it categorical? Is it categorical?
No.
Okay, it is numerical. Numerical what? Somebody said it. Discrete. Serum bilirubin.
Numerical.
Supposing I say serum bilirubin can be categorical.
Say high or low.
High low.
When you say high and low, automatically bilirubin becomes categorical. Again, whatever I say ultimately has to answer your research question. When you convert continuous data into categorical data, it's called as collapsing the data. Why do we collapse data?
To
To
hide.
compare.
No, sir.
To compare.
Someone do it. Why do we collapse data? Why can't I just sit with my whole bilirubin values and feel happy? Why do I collapse it into high and low?
Convenience of the
To treat your patients. Ultimately, when you collapse data, you say that this patient is high bilirubin, not likely to survive, or needs aggressive therapy. Patient low bilirubin, likely to survive. Okay, so you treat it in a different way. It helps you to take decisions. And it's like seeing a movie, Dawn 2. I like Shah Rukh Khan, I don't like Shah Rukh Khan. Or I like this, or I don't like this. All of us do that. We tend to think categorically. Think about it. We never think continuously. I like this one, I don't like this one. I like this teacher, I don't like this teacher. So you tend to think binary categorical. So categorical data, collapsing the data, allows you to treat your patients, allows decision making. Gender. Yes. Question is it categorical? Yes?
Yes.
Nominal or ordinal? Ordinal, no? Women always sit
She said it first.
Yeah, she's telling.
If
At home would have.
you listen to Belafonte, then severity of hemophilia, categorical what?
Ordinal.
Ordinal. Reduction in blood pressure after treatment with an antihypertensive drug. Yes, it's numerical, could be categorical, depending on your research question. Which of the following are numerical data? Number of episodes of disease in a patient in a year.
Yes.
Numerical what? Discrete.
Discrete.
Yeah. Serum bilirubin. Same slide.
Numerical.
It's essentially numerical. You start by measuring bilirubin and it's only later that you collapse it. Gender. Question is it numerical? The answer is not numerical. Severity of hemophilia? Not numerical. Reduction in intraocular pressure following treatment? It's essentially numerical, but you may eventually convert it into categorical data. Yes, you will need to have cuts off for that again, which is defined in your protocol. Now, true or false? Which of the following statements is true about ordinal data? Talking about ordinal, order, categorical. The data are discrete and can take one of many values. False. Data are continuous and follow an ordered sequence. They may not be continuous. They follow an ordered sequence, may not be continuous. Right? Continuous by definition applies to quantitative data. Data are categorical. Ordinal data is a type of categorical data. Yes or no? Yes. Third one, no. It's yes. Categories of responses are ordered. You have T, na? Yes?
Yes.
There can be only two categories of responses. False. No? You can have more than one category. Mild, moderate, severe, very severe. Select all of the data that you think are nominal, no order, categorical. Height. What is height? How much? No? So it's numerical. Ethnic group. It's categorical, ordinal or nominal?
Nominal.
Nominal. Social class, 1, 2, 3, 4. Categorical, ordinal. So the answer is not nominal. Age categorized as young, middle-aged, old. Categorical, ordinal, not nominal. Age in years. Numerical. So the only answer, the right answer is ethnic group. Right? So if you look at this age, we've suddenly collapsed it into young, middle-aged and old. Again, to answer the research question. So again, the point that ultimately your data has to fit the research question that you're trying to answer. State true or false. A nominal variable has categories which can be ordered. False. Quantitative data occur when the variable takes a numerical value. Ordinal variable is a type of numerical data. An ordinal variable is a type of numerical data. False. Ordinal is categorical. Binary categorical variables could be nominal or ordinal. True. Nominal data are measurements.
False.
It's false because nominal data is a type of categorical data. When you measure, you quantitate. So this is quantitative data. So remember, the type of data, this is the take-home message, the type of data and the type of distribution, parametric or non-parametric, will determine the type of statistical test you will use to analyze your data. So just tell me when to stop and finish. 12:13.
Yeah.
What I'll do is I'll quickly cover distributions and then I'll skip the confidence intervals and I'll go to sample size. I'm going to cover basically 3 distributions and at the end of it we'll have problem solving. Normal distribution, binomial distribution, something called as the Poisson, I don't know how to pronounce it, Poisson-Bernoulli distribution, the guy who discovered the Bernoulli phenomenon, and problem solving. The normal distribution is also called as the Gaussian distribution. It's named after this guy, Charles Gauss, German mathematician, who is supposed to have plagiarized it from another French mathematician, Alexandre de Moivre. ultimately it's credited with his name. It's essentially a bell-shaped curve which is symmetrical about the middle, right? So this is your normal distribution here. 50% of the data falls on the right of the curve and 50% of the data falls on the left of the curve. Can anybody tell me, for us as clinicians, why is the normal distribution so important? Why are we talking about the normal distribution?
To label the categorize patient in
Define
as
a
abnormal or
Define disease, categorize patients, why?
Reduce
Normal
the
is
burden
skewed
of
to the right or left, your results will vary.
More important, it's a more philosophical question.
Because nature usually
Exactly.
distribute things in
Normal is usual, something which occurs in nature. Most biological variables, rule of thumb, are normally distributed. Most biological, I'm not saying all. And I know Dr. Nayak will say IOP is not normally distributed. IOP is not normally distributed. It follows something called as a log normal distribution. Whether it's your height, whether it's your weight, whether it's your blood pressure, whether it's serum cholesterol, most of it follow the normal distribution. The average biological variable that we deal with on a day-to-day basis tends to be, I'll use the word tends to be normally distributed. For example, if you're looking at how long an average Indian lives, that will be somewhere here, which is 65 I think for women and 67 for men. But you will have neonatal deaths, infant deaths, and you will also have people who touch 100, right? So that's what your normal distribution really tells. It's a theoretical distribution. So like he said very rightly, it's also something which occurs naturally, and therefore you've written an equation around it. Kind enough to us have been some statisticians who classified this area under the normal distribution curve, right? So when you say that the average Indian lives for 65 or 67 years, that's here in the center, right? But what you're also interested in knowing is how short-lived is one person here and how long-lived is the other person on the other side. So this variation is given by the term standard deviation. How far away are individual data points from the center of the normal distribution curve? So the normal distribution gives you the mean at its center. It also gives you, like he said, the spread of the data, the skew in the data. Right? This skew or variability in statistics is called as the standard deviation. So one standard deviation on either side represents about 65% of the population. Two SDs represent about 95% and three SDs about 99% of the population. So if you have the mean and the standard deviation, you can very easily construct the normal distribution curve. State true or false. Normal distribution is the distribution of a variable measured on healthy individuals. All individuals. All of us actually deal with disease, no? It can be measured on healthy individuals, but we also measure it on disease. Is skewed to the right. Has 95% of its observations contained within limits defined by one SD.
false.
Is completely characterized by its mean.
False.
Mean and standard deviation. It is a continuous probability distribution.
True.
It is true. If the mean of a normal distribution is 20, standard deviation is 5. 95% of the data lie where?
15 to 20.
Oh, sir. 2 standard deviations, no? So, what's the right answer? 10 to 30. 2 SD, no? 5 to 10. So 20 minus 10 is 10, and 20 plus 10 is 30. This is a trick question, so think and answer. Which of the following variables are likely, so you can argue with me, likely to follow a normal distribution? The number of hospital attendances in a year in a sample of adults from the general population.
No. Need not be normal distribution.
What kind of data is that? Who comes to the hospital?
Not only adults.
Sick, we are healthy, presumably. Sick, no? So that is categorical data. Sick, healthy. So the people who come from the community are sick. So this is actually not normally distributed. Survival times following a heart, liver, lung, renal transplant.
Not normal.
Why is it not normally distributed? Rule of thumb, survival is never normally distributed. Why? You would know that. When is the mortality the highest? In post-transplant? Initial period.
Immediate post.
Immediate post-transplant period, and then it sort of tapers off, right? So this is not following the curve. Heights of individuals in a population. Something. Ages of first year medical students.
Normal distribution.
So when you ask the second MBBS students I teach, they'll say, oh madam, but nowadays it's 17 to 27. Depending number of times you give the CET, I suppose. I think the answer is no. But like sir said, can be, so I'll leave it at can
Why
be.
can be? It should be no.
It should be no, but like they said, I have asked somebody to do this, that you actually plot the first MBBS students. They are actually of varying ages now. It's not that everybody joins now at 17 and 18 like we used to. There is a skew here,
Maximum
but I would
maybe
still,
first
yes,
MBBS.
I would
Maximum
still
maybe
say
in
that
first 1 year or 2 years.
not normally distributed. Last question. Shoe sizes of 11-year-olds in a mixed school. Yes, maybe, can be, could be.
Depends on the sample
Depends.
size in the class. If they are all from the same age, yes. If they are from different
It's a
age,
mixed school class. Again, the answer is, like I said, the question is likely to follow a normal distribution. Answer is yes. No. 11-year-olds, no? No. But then, like you said, if you have a huge sample of 1,000 people in the class, like in Ghana, I don't know. Okay, two other distributions, very quickly. The binomial distribution, very simple, applies to categorical data. It's a yes-no distribution. Smoking, non-smoking. HIV positive, HIV negative, right? Immunosuppressed, immunocompetent. This kind of binary categorical data follows the binomial distribution. And the last distribution we should know, there are many distributions, is the Poisson distribution. The Poisson distribution simply models very uncommon events. All of you would be aware of this pulse polio campaign. Right? So you have this attenuated polio virus which is given out. One of the problems is acute flaccid paralysis, right? Because it's a live attenuated virus. But we still give this vaccine because the benefits of giving the vaccine far outweigh the risks of acute flaccid paralysis towards polio elimination. The occurrence of this acute flaccid paralysis, which is so very limited, so very minimal, follows a Poisson distribution. Essentially, it's a distribution which models the occurrence of something like the tsunami, something like the earthquake in Japan, although I would say that now that's becoming more normal like in Japan, right? So, or anything which is a really rare, like volcanic eruption for instance. So these are events which you don't foresee. These are very rare occurrences but can be modeled on this Poisson distribution.
How would you look? Is there a graphic?
All of them have graphs. I haven't put them. They all have equations. They all have graphs which are nothing like the normal distribution. State true or false. Right? This is binomial distribution. Is a distribution of a continuous random variable.
False.
Is always symmetrical. Can it be symmetrical?
It can be, it can
If you toss a coin, heads and tails, that's binomial distribution. Can it be symmetrical? Answer is false. It's always symmetrical is no. Can it be symmetrical? It can be symmetrical. The answer here is false. Nothing can answer. Is used for making inferences about proportions.
Can be.
This is not a can be answer. Is used for making inferences about proportions. When you toss a coin, there are two possibilities. You either get heads or you get tails. So it is 1 divided by 2, which is 50%, which is a proportion. Categorical data, binomial distribution, always expressed as proportions. So the answer is yes. Last question. Please answer correctly now. Please. We've learned only 3. I have only 3 questions. Yes?
Binomial. No, it'll be normal Gaussian.
Arey Baba, Gaussian. Anybody?
Poisson.
Supposing I say it's binomial, like so said.
It would be accident, yes or no, then I can make it up.
So the Poisson distribution is a special type of the binomial distribution, right? When you go on the expressway, you either come out alive or you come out dead, right? 9 out of 10 times you will come out alive. So it's a very rare occurrence, event itself, and therefore it's Poisson. But because it's two alive dead, it's categorical, therefore it could also be the binomial distribution, right? So it's binomial, but the Poisson variant of the binomial. Everybody's happy?
Happy and obese.
Sorry?
Happy and obese.
Happy and obese. That I don't know. Last time I took this, somebody said it's different if it's Leelavati and Kelu. So I shall let that slide.
Tell me, when you calculate any normal